Assalamu alaikum. Good day, everyone. Uh, I would like to thank the organizers for giving me the opportunity to talk about the deadly cycle in Gaza, which is composed of AMR, malnutrition, and infectious diseases. I am Abdul Raouf El Maname, a PhD in microbiology from the Islamic University of Gaza. The content of this presentation include introduction, which will focus on why Gaza is now the perfect environment for infectious diseases. The core concept, the vicious cycle, malnutrition in Gaza, which is the foundation of the crisis. Infectious disease surge in war conditions. Also, AMR will be included as a silent accelerator for this problem. And we will talk about how to break the cycle through integrated interventions. At the end, we will try to make some conclusions and some call for actions. Gaza is a fertile environment for infectious disease due to several reasons. I would like also to emphasize that the pre-war baseline high population density, which is considered one of the highest population density in the world, 97% of the water is contaminated, and there was a report by the WHO that Gaza is inhabitable in 2025 due to the lack of safe drinking water. The current war condition, near total collapse of WASH infrastructures, healthcare, at less than 15% capacity, mass displacement, and the scientific reality is that all pathogens from a microbiological perspective can thrive in such conditions and can multiply and easily spread to people. Key indicators like the case fatality rate from infectious disease has increased from 3 to 5 times since the onset of the current hostility, which is reported by the WHO. At the right of this screen, a map of Gaza Strip that is before the war, with a number of 2.2 million people, and is considered, as I said earlier, one of the most populated areas in the world. Now Gaza can be described differently because the North Gaza was totally destroyed, inaccessible to mostly to people. Also, Rafah and parts of Khan Yunis were totally destroyed, both agricultural land in people lands. And in addition to that, this strip that appears here is also called the yellow line, is occupied totally by the Israelis. So this constitutes almost 50% of the Gaza area. 2.2 million were living in the 100% of Gaza. Now they are living in 50%, making them really the most populated area in the world. The vicious cycle composed of malnutrition, infectious disease, and antimicrobial resistance. It can be noticed from the diagram that malnutrition weakens the immune system, increases susceptibility to infection, while the infectious diseases, of course, need antibiotics. Inappropriate use of antibiotics due to system collapse, healthcare system collapse, will lead to antimicrobial resistance. Antimicrobial resistance means greater, more deaths, more amputations, prolonged hospital stays, and greater malnutrition. So it is a cycle. It started with a malnutrition and back to increased. That's why we call it vicious cycle. The effect of malnutrition on the immunological status of the people is very well established in the literature. 90% of the population experiencing acute food insecurity, 30% of children and less than 2 years acutely malnourished, 15% severely wasted. Also, there is a micronutrient collapse, deficiencies in many elements like iron, vitamin A, zinc, and B12. Of course, these are not just claims they are reported from international organizations such as UNICEF and WHO. One of the major consequences of malnutrition or starvation or famine is that the immune system breaks down, and one of the most important immune components, let's say, the mucosal barrier breakdown, wherein the microbiota, which is a very beneficial bacteria found in the intestinal tract, will collapse and thus not doing their function well. And there are many consequences, and I believe that in this conference, one of the two of the presentation has focused on the malnutrition on the microbiota. Immunodeficiency, like reduction in CD4 T cells, impaired neutrophil functions, and hypo-responsive vaccination, meaning that they will not respond well when they are vaccinated, leading to high coverage of vaccination, but the effectiveness is low. Cytokines dysregulation, which reduces the inflammatory response. Gaza-specific factors, stress-induced hypermetabolism. This is a very vital issue wherein stress plays a very crucial role in increasing the metabolism and thus exacerbate catabolism, which also leads to poor absorption and other related effects, including immunity. Infectious disease surge. There have been well-known factors that play a very important role in increasing infection. We have the agents, which is present everywhere in the world with varying degree of spread, and the environment and the host. The agent, we will hypothesize that it is the same as in every country in the world. However, the environment is very different because of the system collapse, water treatment, wastewater seepage over the streets of Gaza, and no treatment at all. Hosts are immunocompromised due to trauma and due to malnutrition and famine. This also increases the chances of disease transmission, as well as pathogen development, let's say mutations and increased resistance to antibiotics or to antimicrobials in general. The WHO has documented many outbreaks in Gaza Strip. I would like to emphasize on diarrheal diseases, respiratory infections, skin diseases, scabies, lice, hepatitis A and meningitis. Key factors, the routine vaccination has collapsed for a period of time due to security reasons and the war condition. Measles, polio, immunity gaps emerging. AMR, which is the accelerator for this problem or this cycle. Empirical treatment dominance, no lab to diagnose the actual pathogen and to test for susceptibility testing, thus giving no choice for physician but to rely on empirical treatment. And that is, of course, you know the consequences of giving antibiotics without culture. Drug shortage, inconsistent supply, subtherapeutic doses, and truncated courses also. Wound management crisis, thousands with traumatic wound treated in unsterile conditions, no infection control practices at all, even in the biggest hospital, due to shortage and due to the large number of casualties entering these hospitals. Crowding and transmission, resistant clone easily spread among closely residing population in shelters and even in hospitals. One of the hospitals that I visited during the war, patients are on the floor, no space for all patients. And in addition to that, many of the people who were displaced have taken the yards around the hospital as a shelters for their children and their families. Expected resistant profile. Before 2 months, we discussed some of the results that has been collected from Nasser Hospital, which showed very high resistance to carbamazepines like Escherichia coli and Klebsiella, also including the extended spectrum beta-lactamase or ESBL genes. Acinetobacter baumannii, which is a very multi-drug resistant one, especially in wounds and respiratory infection, and very common in hospitals. Many were isolated with pan-drug resistant, meaning they are resistant to all drugs available in the hospital. Staphylococcus aureus, especially the methicillin-resistant Staphylococcus aureus, also its prevalence is surging in hospitals. Consequences: the antibiotics that were considered previously as last line now are becoming first line, and that is a very bad news. In this slide, we will focus on the figure. We have the orange columns and the blue columns. This is the baseline CFR, case fatality rate, pre-war, which is the blue one. We can see the childhood pneumonia. It has increased from 1%, about 1% to 8 to 12%. Watery diarrhea from less than 0.1 to 2 to 4%, while respiratory infection from 2 to 3 to 15 to 30%. And this was calculated based on the Syrian war conditions, which is really can be catastrophic. Even the war has stopped because the conditions are still there. No improvement in such conditions. Breaking the cycle, we have intermediate interventions from urgent to 6 month, survival triage. Nutrition, we have to provide those patients with ready-to-use therapeutic food. Multiple micronutrient powders, blanket distribution, meaning to cover all the needy people. Infection control, chlorination and water tracking at scale, safe excreta management, wound care kits with thousands of these, or maybe millions of these wound care kits are required. Antibiotic stewardship, even in conditions like in Gaza, we have to try to implement antibiotic stewardship through empiric protocol standardization, strengthening syndromic surveillance. The medium-term interventions, which is from 6 to 24 months, to bring back the health system again. We have to restore diagnostic capacity, which is very vital in the efforts of fighting infectious diseases. Molecular surveillance using portable PCRs, for instance. Re-establishing primary care, including the vaccination campaigns. Regular anthropometric screening for malnutrition. AMR containment. Formal antibiogram development. Infection prevention and control measures should be implemented in all hospitals and clinics. One Health approach, which include animal and environment surveillance, resistance spread via wastewater, also very important. Recommendations to humanitarian actors who are involved in the Gaza or are intending to be involved in Gaza Strip. They have to integrate the malnutrition in their efforts. A nutrition and health program must be co-located. Measure AMR. We have to include simple resistance markers in disease reporting, advocate for medical supply consistency, and interrupted antibiotic supplies, which cost life should be a vital rule for humanitarian actors. For healthcare clusters and WHO, we have to establish Gaza-specific treatment guidelines reflecting local resistance reality. We have to create also a rapid diagnostic supply chain for key pathogens, in addition to implementing centralized but secure electronic health records to track the cycle. We have recommendations also for reconstruction planner. You know, Gaza is almost 85 to 90% totally destroyed. Or partially destroyed. Total and partial, maybe, I think, I believe, because I am living in Gaza right now, no place in Gaza was left the same as before. Even those buildings which are still standing, a great deal of destruction has inflicted in this building. We have to build back with WASH resilience, decentralized health capacity, which is a very vital component of any emergency intervention, even for the future, because this is a place where conflicts and wars are continuous. Include AMR labs in early reconstructs. Even mobile AMR labs would be of value. To summarize, we have 4 points. Gaza represents the most extreme convergence of AMR, malnutrition, and infection drivers ever documented. When I say ever documented, I really mean it, because we have the perfect environment for infectious disease spread, which include also in several factors, but the antimicrobial resistance and malnutrition. The cycle is already operating and killing people. Without targeted intervention, the cycle will become the dominant cause of civilian mortality long after active hostilities end. Breaking the cycle requires simultaneous, integrated actions on nutrition, infection prevention, and antimicrobial stewardship. The take-home message of this presentation is that the world's ability to stop this cycle in Gaza will be a lesson for future conflicts and a testament to the power of integrated public health sciences. These are the sources that I relied on preparing this presentation. Thank you so much again for the organizer for this important event.